Good afternoon, everyone. Thank you for joining us for Hernia session. My name is HyungJin Kim from the Catholic University of Korea. I'm a chair of this session with Professor Yoo. And Professor Yoo, would you please greet our participants?
Thank you, Professor Kim. I'm Seung-Bum Ryoo from Seoul National University Hospital, Korea. And I'm very pleased to join in this conference as a co-chair. Thank you.
Okay, then I will chair the first two speakers, and next speaker will be introduced by Professor Yoo. This session is all about. The session is all that you should know about ventral hernia. In this session, after each speaker's video stream, we will have Q&A with the speakers. So, and I'd like to introduce the first speaker. The first speaker is Professor Ji-Hoon Kim from the Catholic University of Korea. And then he will give a lecture on comparison of various open techniques for ventral hernia. Please stream the first speaker's presentation.
Good afternoon, ladies and gentlemen. I'm Ji-Hoon Kim at the Catholic University of Korea. It's my honor to lecture at this great conference. I'd like to tell you about comparison of various open techniques for ventral hernia. There is nothing to disclose. And taking picture of presented slide is allowed. See the introduction. Although there are various techniques, I think the most important thing in ventral hernia surgery is the reconstruction of linea alba. This is important for hernia recurrence and recovery of trunk muscle physiology. If there is ventral hernia like this, the lateral abdominal muscles contract and become fibrotic, and back grow bigger and bigger. If this situation persists, the counterpart muscles, diaphragm and back muscle, will weaken. There are various procedures for ventral hernia repair. There are three procedures for ventral hernia repair: primary closure, open mesh repair, and laparoscopy or robotic hernia repair. And these two techniques are for reducing tension and making primary fascia repair possible. Anterior and posterior compound separation technique and adjunct interventions such as botulinum toxin injection, progressive pneumoperitoneum, and tissue expander. Now let's look at each technique in detail. Various weapons are here. Each has its pros and cons. I think it's important to use the right weapon for each situation. The first is primary repair. The 2014 guideline recommend the suture repair only for defects less than 2 centimeters. However, in the 2019 guideline, it has been changed to 1 centimeter. In conclusion, mesh reinforcement is recommended for repair of all ventral hernia larger than 1 centimeter in a clean case. The next is open mesh repair. First, if we compare laparoscopic and open surgery, laparoscopic surgery has more advantages such as fewer superficial SSI, less blood loss, less pain, shorter hospital stay, and less use. But RAS guideline says that they have comparable postoperative pain and comparable recurrence rate. And the old guideline said that laparoscopic hernia repair is feasible for defects rather than 15 centimeter and even for defects of up to 880 square centimeters. But new guidelines recommend laparoscopic techniques only for smaller than 15 centimeter. And laparoscopic technique has disadvantages such as steep learning curve and bowel injuries. Let me tell you about the location of the mesh. First, you shouldn't put the mesh at the inlay location. This has a very high recurrence rate. You can put the mesh in any position such as overlay, underlay, Electro-Rectus. However, the best location for open surgery is Electro-Rectus. The Electro-Rectus repair is gold standard for open ventral hernia repair. So, how big mesh should we put in? The mesh area to defect area ratio is more important than a single mesh overlap length such as 5 cm. It recommends that the ratio should be at least 16:1. In other words, the radius of mesh used should be at least 4 times than radius of defect. Let me tell you about compound separation technique. The compound separation technique is for reducing of tension and reconstruction of linear alba. What is the compound separation technique? There are two types of CST. The first is the release of external oblique muscles and is called anterior CST. The second is the release of posterior rectus sheath and transversus abdominis muscle, which is called posterior CST. We can extend the length of 8 to 10 centimeters at the center level through the anterior CST. The indication of CST is midline and large hernia, and we can also use it for contaminated wounds with tension because the usual mesh is not mandatory, but CST are best combined with the usual mesh to reduce recurrence rate. This is guidelines for CST. This is what I already said. Let's see the techniques for anterior and posterior CST. The first thing you need to know is the neurovascular bundle in the abdominal wall. It is attached to the inside of the internal oblique muscle and runs. So you should never cut the internal oblique muscles. You can cut external oblique muscle or posterior rectus sheath and transverse abdominis muscles. Let's see the anterior component separation. This was first reported in 1990, so it is called classic component separation. The technique is not difficult. Open the skin through the old incision and find the anterior rectus sheath. Continue the dissection along the anterior rectus sheath enough to put a large mesh. After that, open the medial side of the external oblique aponeurosis, like this picture. After close the linea alba, put the large mesh over the fascia. I think that it's time-consuming, but it's not a difficult technique. However, this technique has a fatal weakness. The perforators that connect deep and superficial vessels are sacrificed. So the SSI rate is high and the skin necrosis rate is up to 25%. So there are other techniques that make up for the shortcomings of anterior CST. It's a peri-umbilical perforator sparing CST. As you can see here, tunneling only over the external oblique muscles, not whole area. And you can do this with laparoscopy, like this. However, last two techniques, perforator sparing CST and endoscopic CST, have the disadvantage that it is difficult to insert a mesh. However, the three techniques of anterior CST have a comparable rate of partial closure and hernia recurrence rate. So, in order to reduce post-operative wound mobility, you should consider perforator sparing or endoscopic CST as an alternative to open CST. Now, I'd like to tell you about posterior component separation technique. As I told you, the Electro-Rectus repair is gold standard for open hernia repair, but there is a limitation because there is not enough space for large mesh for large defect. So we need the posterior component separation technique. First, approach via Electro-Rectus space like this. As you can see, the end of transversus abdominis muscle is more medial than internal oblique muscle. So we can see the transversus abdominis muscles after cut the posterior rectus sheath. Note that the neurovascular bundles is located behind the medial of rectus muscle, so open the posterior rectus sheath on 1 to 2 cm medial side of medial margin of rectus muscle, like this. Now you can see the transversus of the mid muscle. And open the transversus of the mid muscle like this. Now you can see the transversalis fascia. After open the full length of the transverse of the mid muscle, dissection as far as possible between transverse of the mid muscle and transversalis fascia. Now we can get additional 8 to 12 centimeters on each side, and we can repair of linear alba without tension. You can see releases transversus of the mid muscle. This is transversalis fascia, and we can insert very large mesh. This posterior CST have similar wound morbidity and recurrence rate compared to endoscopic or perforator sparing CST. For intermediate to large defect, we should consider endoscopic or perforator sparing anterior CST or posterior CST rather than open anterior CST. So, guidelines recommend posterior CST can be applied for complex ventral hernias. This is last chapter, preoperative adjunct interventions. We can use botulinum toxin for release of lateral abdominal wall muscles. It can make direct fascial closure without CST. This is progressive pneumoperitoneum. There is no protocol because it has been attempted by numerous different methods per study. For example, between 5 and 15 days prior to surgery, insufflation with 1,000 to 4,000 milliliter per session was repeated every day in some studies. This is a tissue expander to stretch skin or the underlying fascia, allowing primary fascia closure in large hernias. Tissue expander can be positioned subcutaneously in case of skin loss, intramuscular between the external and intraoblique muscles in cases of large ventral hernias. There is no consensus regarding indications, optimal technique, and associated risks. These techniques have low evidence, so there is no recommendations yet. It's conclusion of my lecture. First, we have to use mesh in ventral hernia repair. Second, reconstruction of linear alba is important. Third, for small to intermediate hernia, we can use laparoscopy or robotics hernia repair. And among the open techniques, Electro-Rectus repair is gold standard. Lastly, for large hernias, we have to consider posterior CST or endoscopic or perforator sparing anterior CST. Thank you for your attention.
Thank you, Professor Seung-Bum, for your comprehensive lecture. You introduced various technique open technique for the ventral hernia repair. Thank you. I think we have to tailor the treatment depending on the size and location of the incisional hernia. So until now, we do not have a question from the floor, but I was very interested for your lectures, and I want to ask a short question. Do you have any experience of using the botulinum toxin for hernia repair?
Thank you for question. I have no experience yet, but I already wanted to perform the injection of botulinum toxin in case of large hernia, but there's no case of loss of domain recently. Yeah.
Okay.
Okay, thank you, Professor Kim. Okay, I'd like to introduce the third speaker, Professor Se-Jin Baek from the Korea University College of Medicine. And as you know, she's a pioneer in robotic surgery. And she'll give us a lecture on robotic ventral hernia repair. And please stream the presentation.
Good afternoon, everyone. My topic is robotic-assisted laparoscopic ventral hernia repair. There is no disclosure. Since Leblanc and Booth first reported laparoscopic ventral hernia repair in 1993, this surgical method, mainly intraperitoneal online mesh, has often been used. There have been pros and cons about the necessity of close-up facial defects, but there is a common agreement that it is technically very difficult to perform this with a laparoscopic instrument. In order to overcome this problem, percutaneous method using suture pressing device or hybrid techniques has been used. But it is still not easy and the pain is large. Therefore, the penetration rate of laparoscopic surgery has been only about 20%. In the 2010s, as robotic systems were applied to the laparoscopic ventral hernia repair field, this method has increased rapidly. This is the 2021 annual report of Intuitive Surgical, where robotic hernia repair increased by 158% from 2015 to 2020. Among them, the area of ventral hernia repair indicated in purple also increased significantly. Accordingly, the advantage of minimally invasive surgery, such as less pain, short hospital stay, and low complications could be fully applied, as well as new surgical methods that were not attempted in conventional laparoscopic surgery. Currently, robotic-assisted laparoscopic ventral hernia repair methods include the IPOM, transabdominal preperitoneal technique, enhanced view or extended thoracic extraperitoneal technique with or without transverse abdominis release, transabdominal Electro-Rectus umbilical prosthetic technique, and subcutaneous only laparoscopic approach technique. We will look at these techniques one by one later. Patient positioning is the same as for conventional laparoscopic ventral hernia repair. Spine position, arms tucked at the sides. Flexing the table will expand the distance between costal margin and anterior superior iliac spine if more space is needed for port placement. This can also help minimize the risk of collision between the robotic-assisted surgical device and the size or face. This is a port placement that is commonly used in robotic ventral hernia repair. 3 ports should be placed laterally in order to access the ipsilateral side of the mesh or tissue flap. In case of double duct, Additional posts are also placed on the opposite side. Next, let's look at the techniques of ventral hernia repair that can be performed with the robotic system. IPOM is the method of repairing hernia defect with an intra-abdominal approach and applying mesh by online method. Previously, Professor An gave a lecture on laparoscopic IPOM, which has similar advantages and disadvantages when implementing the procedure as a robot. The advantage of this technique is relatively easy mesh placement and no need to close the peritoneum. However, the major disadvantage of this procedure is that the risk of adhesion online mesh is higher than that of other procedures, which can cause subsequent abdominal operations and complications. Transabdominal preperitoneal procedure was previously difficult to attempt with laparoscopy, but with the introduction of the robotic system, it became easily applicable and more usable. As inguinal hernia repair, flap incision is made through an intra-abdominal approach, then preperitoneal dissection is performed, and hernia defect is closed by robotic suturing. After fixing the mesh, the peritoneal flap is finally closed. The advantage of this technique is that the mesh position against the abdominal wall rather than the peritoneum allows the mesh to contact more abdominal wall with less fixation. The disadvantage is needed to close the peritoneum, which is often thin and may not hold suture well, and it is only feasible for relatively small defects, typically less than 5 cm in diameter. Next, robot extended TP and transverse abdominus release method are also available. This is a method of creating a retromuscular space with the TP approach and placing mesh there. Robot extended TP method is also similar to laparoscopic method. In the next lecture, Professor Kong is going to give you a detailed lecture, so let's move on. Since this robotic extended TP starts within the abdominal wall space, there is little need to extensive adhesiolysis, and TAR can be performed together, which is useful when applying a wide mesh to a large size defect. However, the procedure may be difficult for novice surgeon. Operation time is long, and hematoma within the Electro-Rectus space may occur. Next is the robotic transabdominal Electro-Rectus umbilical prosthetic technique. This procedure is similar to TAPP, but it is a method to create a retromuscular space by dissecting the posterior rectus sheath as well as the peritoneum together. The advantage of this procedure is similar to TAPP, and the disadvantage is that it can be applied only to small defects, and hematoma or umbilical skin necrosis can occur. Finally, there are subcutaneous online laparoscopic approach, scola method as ventral hernia repair method that can be implemented using a robotic system. As the name of the procedure, this is a method of dissecting the subcutaneous space above the anterior rectus sheath, repairing the hernia defect, and then placing the mesh. This has the advantage of less pain and less possibility of bowel injury than other procedures, but it has mechanical disadvantage and may increase the risk of retraction and fibrosis of subcutaneous tissue or skin necrosis. There are various techniques for robotic ventral hernia repair, but the results for these are not sufficient. In terms of operation time, robotic IPOM was the best, and robotic TAPP showed the longest operation time. In terms of audiologisis during surgery, large mesh application, and early postoperative complication, the robotic extended TEP method was generally excellent. But in late result, all procedures were similar. There were some RCTs compared to robot and other surgical approaches. Robotic ventral hernia repair took longer time, cost was expensive, and most of the surgical outcomes showed similar results both in comparison with laparoscope and open. However, in comparison with open method, robotic surgery was superior in complication. Next, let's look at the video clip of the robotic TAPP ventral hernia repair that I did. This is my first case. The patient, a 57-year-old female, was performed laparoscopic anterior resection with sigmoid colon cancer 1 year ago and later developed ventral hernia. The hernia defect size confirmed on CT was 5.3 cm and her BMI was 21.5. Straight poles were placed on the patient's right midclavicular line. I used the curved scissor for the right hand and a cardiac forceps for the left hand. But the grasping power for cardiac forceps was too weak, so from the second case, Maryland forceps were used for the left hand. First, incision was made in peritoneum and preperitoneal dissection was performed. After dissecting the hernia sac, the peritoneum beyond the midline continued to dissection. Next, I am closing the hernia defect using 10V sutures. If you look closely, you can see that the fascia as well as peritoneum were dissected together on the opposite side. And peritoneum is very thin, so it can be seen that it is very much torn during the dissection. This is to fix the mesh using stitching. Finally, I closed the peritoneal flap using 30V sutures. Peritoneum had many torn holes, so it took a lot of time to repair them one by one. Nevertheless, it can be seen that the mesh is exposed through the remaining small defects. The total operation time was 350 minutes. There was almost no pain after the operation, and she was discharged without any special problems on the third day after the operation. It is well maintained without recurrence or other complications at follow-up CT at 1 year postoperatively. I have had only 3 cases so far, and although it is a very short experience, I will share some tips on robotic TAPP ventral. First, it is appropriate for patients who have small-size hernia defect and who are slightly fatty rather than those who are too skinny. If not, it is better to consider applying the IPOM or extended TEP method. In order to facilitate peritoneal dissection, it is recommended that posts be located as lateral as possible and the spacing between posts is wide. It is better to make the incision slightly curved because both ends are particularly difficult because of the angle when performing peritoneal dissection. And as explained in the video clip, fascia may be accidentally included when dissecting the peritoneum beyond the midline. When the peritoneum is too thin, it is possible to consider the modification mixed with the thorough procedure. Finally, it is important to choose the equipment that is comfortable for surgeon. In this technique, since swing is performed a lot, It is convenient to use a needle driver with cutting function because it is not necessary to get help from assist every time. However, particular care must be taken not to accidentally cut the thread when using this instrument. And when closing hernial defect or peritoneum, it is convenient to use fobbed suture. In summary, robotic ventral hernia repair has been increasing rapidly in recent years, and many different techniques are possible using a robotic system. Most of the late outcomes are similar for each technique, but in the case of IPOM, the risk of adhesion to mesh is relatively high. Long time and expensive cost compared to open or conventional laparoscopic surgery is a major disadvantage of robotic hernia repair. In addition, learning curve for surgical tips specialized in robotic approach may be required. However, it is believed that robotic ventral hernia repair can be a very attractive tool for surgeons, as it has a wide range of techniques to choose, and it can provide fully the benefits of minimally invasive surgery to the patient. Thank you for your attention.
Okay, thank you very much, Se-Jin Baek, for a very nice and beautiful presentation. From now, we'd like to start Q&A time for this presentation with Professor Baek. I think until now, we don't have questions from the audience. Let me ask one question. It's very simple questions. There was some procedures developed recently for the incident hernia repair with minimally invasive surgery. So today, many speakers present the IPOM, eTEP, posterior component separation, even the overlay, and you showed us a case of the TAPP. So which one do you think the most advantageous option for this robotic ventral hernia?
Thank you, Chairman. I think the greatest advantage of a robotic system in ventral hernia is easy intercorporeal facial closure. So in this aspect, I think that the procedure that showed the most obvious advantage of the robotic system is the TAPP ventral technique. This is because IPOM or extended TEP can be performed somewhat similarly with the laparoscopic approach. But in the case of TAPP, it is almost impossible to perform laparoscopically. So this is different from which procedure is the best. Yeah.
Okay, thank you. So, and then we always have some cost issue in this robotic surgery. Yeah. So how much did you ask the patient for the payment of this robotic surgery?
All patients who have private insurance covering real costs can be asked if they want to perform robotic surgery or not, because the surgical fee for robotic ventral hernia or robotic recurrent inguinal hernia is set at 3.5 million won in our institution, and it is considerably more expensive than laparoscopic surgery. However, since the reservation for the robotic operating room, especially the XI systems, are always full in our hospital, so laparoscopic surgery is more often selected for scheduling problem.
Okay, thank you. Thank you for your very interesting presentation. And then we're going to move to the next topic. Okay, so next speaker is Professor Seong-Ho from Seoul National University Hospitals. And he's a very famous, and now he dedicated Now he dedicated to the Hernia Society, as you know, and he will give us a lecture on extended totally extraperitoneal repair, eTEP, for ventral hernias. Please stream the presentation.
Good afternoon. It is a privilege for me to present about the extended totally extraperitoneal repair for ventral hernia today. I have nothing to disclose. Traditionally, laparoscopic ventral hernia repair referred intraperitoneal overlaying mesh for a long time until recently. This IPOM repair has been known to be very effective, fast, and safe surgery, although it uses double-layered composite mesh to minimize the adhesion between the mesh and the bowel. There has been still some concerns about the possible adhesion. Occasionally, serious complications such as bowel perforation was experienced. So many new techniques were introduced to avoid the mesh application in the IPOM manner, but to put the mesh in the space separated from the direct contact with bowels. IEHS guidelines newly adopted these techniques and tried to categorize and evaluate them. The space for the eTEP is a retromuscular space above the arcuate line and the preperitoneal space below the arcuate line. These are initially introduced examples of position of the patients and the port sites. It is highly recommended to put the patient in the hyperextension position for better accessibility. When the hernia is located at the lower abdomen, the camera port is introduced from the epigastric area. When the hernia is in the upper abdomen, preperitoneal space at the lower abdomen is approached first from cephalic to caudal direction, and then change the direction to the upper side as shown in this picture. For ventral hernia in the lower abdomen, an important concept you have to know is the midline crossing. Cross the midline through the linea alba. At the beginning, the camera port is inserted at the epigastric area to go inside the retromuscular space of the left abdomen with the camera dissection, like this. Then additional port is inserted at the right side. I use the transparent port with the camera put inside. Now I'm going through the muscle, and you can find the retromuscular space below it. Dissection of this side is often omitted by experts, but I think it would be better to dissect this side too for beginners. Coming back to the left side, 5 mm port is inserted at the lateral margin of the rectus muscle. And then we have to cross the midline. To cross the midline, we have to cut the medial margin of the posterior fascia of the rectus muscle. In the epigastric area, fat near the fasciiform ligament play a role of a buffer and prevent opening of the peritoneal cavity. But we have to be very careful not to perforate the peritoneum. You can see the fat tissue just below the linea alba in the midline. And clearing fat, we have to enter into the posterior fascia of the right side. I'm cutting the medial side of the posterior fascia of the rectus muscle at the right side now. Then I can meet the retromuscular space at the right side that I dissected with the camera before. Now I entered into the retromuscular space of the right side. And I'm changing my camera to the right side again and continue the dissection of the space with the instrument from the left side. The detachment of the linear alba is continued to the lower direction. Now my camera is at the right side, and I'm using two hands via trocars at the left side. Posterior fascia of the rectus muscle at both sides are cut just near the linear alba. Then you can reach the hernia side. The hernia sag is reducted and detached from the fascia defect. We have to cover the fascia defect widely around with a mesh, so we have to dissect further below the fascia defect. Usually the hernia sag is perforated, but now we don't have to worry about the inflation of the peritoneal cavity because enough space was already dissected and secured. A peritoneal tear is closed by a barbed suture. Then the fascia defect is closed. I used 1/0 barbed suture. Not only during the eTEP procedure, but also during the IPOM, it is currently recommended to close the defect as much as possible to reduce the seroma and maintain the body contour and stability. Then a mesh is tailored and put into the space. Usually it is not fixed, but I fixed it to the ventral side to prevent migration of the mesh. Then the air is deflated and the operation is finished. For the ventral hernia at the upper side, it was suggested to approach to the preperitoneal space at the lower abdomen as we do for inguinal hernia. Once we obtain a good space at the space of rectus, we can put additional trocars for camera and the dissecting device. Then dissection is continued to the cephalic side and dissect the midline. When the defect is large, the dissected posterior fascia as well as the anterior fascia are difficult to be closed. In such case, posterior component separation is required. The main concept of the posterior component separation trans abdominis release is cut the posterior fascia of the rectus muscle at the level of the transverse abdominis muscle, and also cut the head of the transverse abdominis muscle to free this muscle and reduce the tension. An important thing is to avoid the injury to the neurovascular bundle, which runs just above the transverse abdominis muscle and perforate into the retromuscular space of the rectus muscle. You can see that the transverse abdominis muscle is not located very lateral in upper abdomen, but located just below the rectus muscle. So if you cut the posterior wall of the fascia at the lateral margin, you can just meet the transverse abdominis muscle. So as the dissection of the retromuscular space continues to the lateral direction, you may encounter the neurovascular bundle. Then you have to go down and cut the fascia and the head of the transverse muscle and continue to the retromuscular space of the transabdominal muscle. This transabdominis release enables you to close the fascia without tension. Then the mesh will cover this whole area. The first approach is similar to TEP for inguinal hernia repair. The first port side is better to be a little bit lateral compared to the port for the inguinal hernia repair. I use the balloon dissector, which can facilitate the dissection compared to the camera dissection. Additional 5 mm port and the 12 mm port were inserted. This 12 mm port will be used for camera port in the next step. For the upper side hernia, an important step is find the arcuate ligament, arcuate line, and enter into the retromuscular space at both sides. The arcuate ligament is attached to the abdominal muscle, so dissection should direct ahead to the upside. Because the space is quite narrow, my personal opinion is that putting additional port would be helpful for beginner. A port at the left side above the arcuate line and the inflation of the retromuscular space would be helpful to find the arcuate line and access to the space. Once the retromuscular space was entered, the midline linea alba is also dissected. The cutting line is just outside the fascia defect, and the dissection is continued to the medial margin of the posterior fascia of the rectus muscle at right side and the left side. Adhesions are detached from the fascia. The area of the mesh cover should be wide, so the dissection is continued to near the xiphoid process. After the dissection, you can see quite a large defect, and it looks like impossible to close this fascia without tension. For the trans abdominis release, additional port at the right side was needed. Here the dissection started from the level of the arcuate line and continued to the upper side. You can identify the neurovascular vendor, and cutting line is medial to that. Here. The tip of the transversus muscle is cut with a hook monopolar device. After sufficient dissection, you can see the posterior fascia and the peritoneum can come to the midline. The next step is similar to close the posterior sheath and the anterior sheath and push the mesh widely inside. So far, there is not enough clinical data in the literature. Last year, Palanivello and his group reported the result of a small prospective study comparing eTEP and IPAM Plus. The operative time of the eTEP was longer than IPAM Plus. I think that 107 minutes is still very fast because of a very skillful hand. It may take 3-4 hours for beginners. The pain score of the eTEP was less than IPAM Plus. There was no surgical site infection in both groups. There was no complication in the IPAM Plus at all, but there was 6 asymptomatic seroma in the eTEP group. Within 6 months, there was no recurrence case in the IPAM Plus group, but there were 2 events in eTEP group. Both patients suffered from the dehiscence of the posterior rectus sheath, and they were reoperated by IPAM manner. This is a potential benefit and disadvantage of eTEP repair for ventral hernia listed from the guidelines as well as my personal opinions. It may benefit from less wound complication compared to the open repair and less chance of direct adhesion of the bowel to the mesh. It can be extended with posterior component separation as per needed too. However, the extent of the dissection seems to be too much for small hernia. Longer operation time and occasional need for energy device increase the financial burden. And at the moment in the Korea, those longer operation time and additional resources cannot be reimbursed properly. The technique is quite difficult and hard to learn, and when the posterior sheath is not easily closed without tension, you must proceed to the TAR, otherwise there is no easy way to solve the problem. And this is connected to the risk of a posterior sheath dehiscence in early postoperative period during the learning curve. I would like to end this presentation by emphasizing the statement of IEHS guidelines for this new technique. Although eTEP has a good potential and theoretical benefit of preventing mesh problem, ongoing evaluation regarding long-term outcomes, operative time, cost, and clinical benefit are needed. The new techniques should only be adopted after adequate training. Thank you very much for your attention.
Okay, thank you very much, Dr. Gong, for your very informative and comprehensive lecture. There is one question from the audience, Kidung Kim. How much do you set the air pressure during the operation?
Yes, thank you for a good question. At the beginning of the operation, the space is very narrow. So usually I use the 12 millimeter mercury, but you can increase about 15 or 16. But if you maintain the high pressure, it tends to cause some CO2 retention. So after certain dissection, and then if you secure the wide space, then you may decrease the pressure. And as maybe the same as the other operation, if you close the anterior fascia, it'll be better to a little bit decrease the closure to ease and lower the tension when you close the anterior defect.
Is it same as the TP for the inguinal hernia, the 12 millimeter?
Yeah, I use 12 millimeter, but sometimes some other operator prefer a little bit lower pressure to identify the what is it, the mortise, the sucker of mortise.
Okay, so we have a time limit. So Professor Kim, would you please wrap up the session, please? HyungJin Kim.
Yes, thank you all the speakers. It was very comprehensive lectures and practical. Yes, this is the final session of the K-cells this year. Thank you all the audience and speakers. And we would like to wrap up the session. Thank you very much for your participation. And sorry, there are some messages.
Oh.
One more question to Seong-Ho. Would you please?
So Seong-Ho, the question from the Dongjin Park, why didn't you use the ligature when doing the, yeah. Why do you use the other device?
Yes, so the Professor Dongjin Park is expert, so maybe it will be helpful. But one time I tried to use an energy device, but it perforated the peritoneum, so I got some fear. So I tried to minimize the peritoneal the injury by using just one by one hooking method. But I think that the ligature is a very good option to very facilitate the cutting the TAR without the peritoneal dissection. And I will try if I have another chance. Thank you very much.
Yeah, so I think sometimes we have a very dense fibrosis in the side. So the hook is a little bit has some advantage than the ligature. And then sometimes the virgin plane, the ligature is very fast to perform the surgery. Yes, it depends on the some patient condition, I think. Okay, so please.
Okay, thank you for the question and thank you for the answers. We have to close this session and thank all the audience, and the closing ceremony will be held at the channel 1. So thank you. See you next year.
Thank you.